Welcome back to Healthwise. With us is Dr. Ty Hargruder from Annapolis General Wound Care Systems. Doc, we was talking about osteomyelitis and also the pressure sores or the diabetic
foot ulcers.
Foot ulcers. Real simple. I can't remember the simple things.
DFUs.
That's right. But we were talking about the X-ray was the way to kind of, that was one of the ways, the MRI also. And we also said Annapolis General had a
top-notch radiology, have forever.
Okay. Well, Doc, also tell us what, we were talking about, what's the general treatment as far as, you said the hyperbarics and you also said nutrition. But let's say, I guess what I wanted to ask you earlier, do you come across cases where it's resistant? We hear about antibiotic resistant.
Yeah, if we can get cultures of the bone for osteomyelitis, it's excellent, because then we know exactly what to treat, because not only do we identify the organism, but we also test it against various antibiotics, and so we'll know which ones it's sensitive to. Without a doubt, the biggest and the one everybody hears of all the time now is MRSA. Methicillin-resistant Staph aureus. It's in the community. It's not just in the hospitals these days. We have a number of agents to treat it, but that typically be the most common. When I was in training the diabetic foot ulcers, you always said it was a mixed infection, and we never cultured staph out of them. And we culture staph out of them all the time. So any treatment for any of our chronic wounds, especially if the patients have ever been hospitalized, starts with treatment for MRSA, and we also add treatment for other organisms until we can identify exactly what the organism is. The diabetic foot ulcers, again, we work them up when diabetics come in to make sure there's not an osteo, make sure their nutrition's under control, make sure their diabetes is under control. A lot of times I'll pick the phone up, call their attending physicians, ask them to please tighten up the diabetic control. They're out of control, and with that we can't get it fixed. The diabetic foot ulcer fixed. Also diabetics in their lower extremities, if they have poor blood flow, that has to be fixed. Again, the General's got some excellent cardiovascular facilities to fix blood flow. In fact, we use a diagnosis called critical limb ischemia. When we identify a limb that has severe blockage that is hampering the ulcer, we put the diagnosis critical limb ischemia. That alerts everybody in the hospital, including the cardiovascular guys, that this is a limb-threatening emergency, and it's not unusual. Tomorrow I'll be at hyperbarics at the Wound Treatment Center at OGH. And if I have a patient, I'll pick the phone up and say I'm admitting a chronic limb ischemia. I'll call the cardiovascular guys, and it's not unlikely that they'll have that patient in the cath lab that night to try to open the blockage up. We have to get blood flow to that leg. In fact, that's what hyperbarics does predominantly, is increases blood flow by causing the growth of new capillaries, which is why it takes so long. It doesn't occur with one treatment. There are some things we treat with, like decompression sickness, carbon monoxide poisoning. 1 or 2 treatments, 3 or 4 treatments is all you need. But when we're growing new capillaries, it takes 30 to 60 treatments to do that. Anyway, to go on with the diabetic foot ulcers, there's some other things that we do at the Wound Treatment Center that commonly are not done elsewhere. We use a number of cover dressings to treat diabetic foot ulcers. We use Apograft, which is a tissue cultured product that causes the healing to come from the body. You put this tissue culture on there called the Apograft. It releases growth factors that basically cause the body's own healing cells to come into the wound and lay down new skin, basically.
Not the Apograft, is it synthetic or is it
No, it's tissue culture. It's made from human tissue, embryonic tissue. Actually, the tissue culture line was probably made maybe 15 years ago.
Wow.
And it's the same ones. It's made in a vat, and tissue cultures, which is kind of the way things are now. You just keep repopulating. You use the same tissue cultures. You make more tissue cultures. It looks like skin, actually.
Oh, okay.
There's 2 other products that I use quite a bit as well. Another one's called Dermagraft. Dermagraft is very similar. It's also tissue culture driven, but it has mostly just the dermal layer, the second layer of the skin. That can be applied over a wound. Does the same thing, basically brings in, growth factors come out and it brings in the healing cells from the body. The third product that I used is a product called Oasis. It's actually a freeze-dried covering of a pig intestine is what it is, which has fibroblast in it, and when you put it on the wound and rehydrate it, it releases growth factors and again bring these healing cells, which are called fibroblasts also, but brings the body's fibroblast into the wound, which lay down collagen, which is important. You have to have collagen because everything builds on that framework to heal the wounds. So it's not a matter of just changing a bandage and washing a wound with soap and water and putting saline,
back in the old
days, saline wet to dries.
Right.
That's not doing anything to enhance the body to heal. That's just making it clean so the body can heal. We use products on these diabetic foot wounds that enhance the body to heal. And the most important thing to tell the diabetics, the most important thing is proper shoe wear. Diabetics typically don't feel their feet, so if you and I are walking on an area of our foot that hurts, but we start walking on the other side of our foot, diabetics don't feel it, so they keep traumatizing that same area, and they end up with an ulcer.
Right.
And that's why diabetics get ulcers, that and the bad blood flow. So that's why their shoe wear is so important. The most important thing my diabetics do, they see me every 3 months in the office. I examine their feet, make sure there's no wounds. I tell them they should examine their feet every week. I tell them to get a mirror in your bathroom, put it on the floor, and look at the bottom of your feet once a week. If you find something abnormal, callus, a crack, get to your doctor, show it to him, make sure you're in the right footwear so you don't develop it.
Right.
I'd rather have patients not develop it than develop it.
Sure. Question, and I know most of the audience probably want to know this. We were talking about these tissue cultures. And of course, in this day and age, everybody's worried about AIDS and all kind of transmitted things. These tissue cultures are a base. I mean, they don't have to worry about that.
No, there's never been with any of these skin substitutes, they call them. There's never been a case of AIDS or any infectious disease transmitted with it.
Sure, well, that's good to know for the audience.
Yeah.
And also, I know y'all use something called, I hear it all the time, me salt.
Me salt's really kind of like the wet to dry dressings that you and I were used to when we first came out. Me salt's a gauze that's impregnated with saline crystals, salt crystals basically. You put it into a wound. The moisture then comes through the wound into the dressing itself, thus pulling all the dead tissue out. And then when you pull it out, it further debrides the dead tissue. So it basically creates a clean wound bed. And we usually use that right at the beginning to clean the wound bed out, to get it nice and clean and ready for either the dermagraft, Apograft, Oasis, or whatever other modalities we're going to use at that point.
All right, Doc. Well, we're going to take a brief break for our message from our sponsors, and then we'll come back and talk some more about osteomyelitis and also the pressure sores or diabetic foot ulcers.